So I think that's what's kind of put the brakes on a little bit, but you're right, it is the expensive drugs too. That's what's driving it too. So again, who has the data, outcome? I mean, these are things I think we should really be working on, getting the data, getting the information, trying to figure out what we're going to do with it. How should we use them? Well, document in a note. My doctors anymore put in the comment in here, this therapy is following NCCN guidelines. I give them points for that when they do that. Okay. The only thing I want to say about this, I just went through a major change in my drugs, and it was a real eye-opener because I got an EMR, and I've got the Lynx machines or the Nucleus machines or whatever these machines are, and they're all tied to your systems, and you have to pay all this money for that. And I really think we should own that technology. I don't think the drug distributor should own that. And I would really like to see MOAS go after that issue and try to figure out how to switch that. So if all of a sudden you're not getting good pricing from one drug vendor and you want to go to somebody else, you don't have to switch the box out. Box stays there. Now, what we could do, I guess, is contract with them and say, the price of the box is separate, so if I switch, I keep the box because I got a contract with you separately. And that's what I did with the vendor that I went with. Okay? But I just don't like it. I just don't like this thing where they own. They're handicapping us too much. Okay, basically we talked about this. Drugs that are not part of the contractual agreement, what should we do to throw it into the equation with payers if drugs are pulled out? The brown bagging issue. That is the dumbest thing. Back east, we've pretty well gotten rid of all the brown bagging. Because, I had one doctor, I had 45 brown bags sitting in her office. When I went through and did the inventories, over $100,000 worth of drugs. That was really brilliant, right? All this brown bagging, the drugs weren't used because the patient didn't show up or whatever. So I made sure that the insurance company knew that they wasted $100,000. So, of course, we talked about the NM coding. I can't go over that anymore. Smaller practice or depository data, we know about that. This is the RVU thing that we talked about a little bit here. That basically, if we go back to that slide where you talk about 10% of the revenue, 15% of the revenue, 20%, that really equates to this work RVU called the $50 work RVU. And all it is really take $50 times the work RVU, not the total RVU. So if a doctor has 6,000 work RVUs, take $50 times 6, that's $300,000, right? That's what the hospital would pay the doctor if he did 6,000, getting 50. But the gold standard is coming up to be 75 to 100 work RVU conversion factor times the work RVU. That's where the compensation ends up. I wish we had more time to talk about that. So again, what I'm trying to say what you could do in your practice is you could do your calculation and see where your doctor's at. My doctors right now are at $49 work RVU. And my margin of drugs was 18, dropped back in January, dropped back to 9%. Okay, and that's why my work RVU went down. So now I'm beating up on the doctor saying, you got to do more level 5s. We're going to document better. We're going to do better because I'm working like heck to get my drug margin up by switching vendors. So I saved $150,000 drug costs by switching. And I've had that drug vendor for 10 years. But somebody else came in with cheaper prices. He went out the door for $150,000. Okay, so I'm saving a little there. So now I'm working on these other issues. Okay. Let's sit back because we're going to run out of time here. Sorry, 2:26 here. Visits, infusion labs, and other services affect the overall expected margin. Visit revenue per doctor increases 100 to 150,000. Meaning, if you follow what I'm saying here and you do the documentation right and you work hard on this, the bottom line, if a doctor's doing 3s and 4s with only 10% level 5s, you look at a $100 to $150,000 gain for the practice per doctor. Hands down, tell you that's what it is. There's no two ways about it. And if I have to add 1 or 2 more FTEs to get that, I think it's well worth the money. In infusion, negotiate higher payments in exchange for drug therapy. That's what that charge master, setting your charges, getting your collection rate, and analyzing that will help you figure that out. To see if we can go back and talk to the Blues and them to see if they will pay us more. Now that we know that the hospitals are collecting more money, we should be the most favored nation status for getting better contracts because if we send the patients to the hospital, they're going to pay more. So why don't pay us a little bit more? All we need is 10, 15%. We're not asking for a lot. Okay. Relative value units, MGMA, of course we talked about that. That's where if you see this slide, the MGMA data, if you go pull that down, you'll see where this work RVU comes from, which is basically data that is really not what I call true data. Okay, this talks about how to get there. It does the calculation, the receipts divided by the RVU, gives you your conversion factor. Okay. And basically, in a hospital contract, so if the doctors are talking to their buddies, where are they at the 75th percentile or below the 75th percentile? And by the way, if you're a doctor doing 90th percentile, what is the 90th percentile? Somebody doing like 700 consults, new patients a year, and most probably seeing about 6,000 or 7,000 patients a year. That's a doctor in the 90th percentile. And hospitals don't like to contract with people like that because they think they're doing something wrong. But nobody stops to think that the guy's working from 6 o'clock in the morning until 10 o'clock at night. Well, shouldn't he get some benefit for that? I mean, if that's the way it is, that's the way it is. But they don't like to do that. So you just need to be aware hospitals, they really like to see doctors in the 50th percentile because that puts them under the radar screen, no audits, no challenges, and that's what they try to do. So that's why hospital contracts are not all what they're supposed to be. Okay. All right. Well, basically everybody knows this. We talked about this. Doctor, right now, if you're billing 3s or 4, you're getting paid like a primary care doctor. That's no two ways. That's just what's happened. That's the reality. Clinical trials. Whoops. I mean, if you guys have heard of Acorn, the guys out of Memphis, we participate in them. We participate in other clinical trials. Right now, it's about break even because the problem is you have to have so much high labor to process the clinical trial work. We've not seen any real benefit of what I call making money. I think I got one doctor because they had some interesting clinical trials out of Acorn that he's most probably going to get $50,000 this year by doing the studies. So people are starting to look at it more, but the problem is what the doctors are telling me is there's not any good clinical trials coming out to participate in. They're all junk. So Marianne just wanted me to make a comment saying, if you're looking at clinical trials as a revenue resource, been there 3 years, we're still about break even. As a matter of fact, I got 6 doctors, only really have 2 or 3 that are really using it. The rest of them aren't even participating. They think it's too much of a hassle. It's not worth the effort. Okay, and of course, Susan Summers, God, we talked about that a lot. Yeah, there's some other books out there. So anyway, let's go back. I want to go through, I think the easiest thing to do with these notes. Let's see here. Oh, here, I got to pull them up here. Okay, you've got some notes handed out to you, and here's the first note. Let's kind of do it this way. I think this would be more productive. Is here we have a patient with metastatic breast carcinoma. And these are live patients. A doctor friend of mine said you could surely use my notes if it helps people to understand what needs to be in a note. See, and again, what I usually do is I go to the bottom. I start at the bottom and work backwards. So here's a patient, metastatic breast carcinoma. Radiologic studies were certainly suspicious for metastasis to the lung, skeletal system, skin, left posterior neck nodules. He's got CBC chemistries he reviewed, so he's got the labs. Okay. Recommendation was made for the patient to have tissue obtained to determine her hormone receptor status. So he's looking to have some kind of a biopsy done. And the patient's complaining some kind of a range of motion. So he's looking for some information there. So he's actually sending a patient to a major institution for further workup and evaluation. So I look at this patient here. He's not doing any chemotherapy, but I know he just spent a lot of time looking at her studies and going back and looking at her diagnosis if I start from there. She's got metastatic breast carcinoma, so she's a pretty, sick puppy. She's weight stable, denies chest pain, severe cough. So you go down. His biggest problem with his notes that I got to talk to him about is he's not putting enough what I call meat and potato in his review of systems. Okay. He's got his past family social history and family history have been reviewed in detail and no updates are felt or necessary. So if I go down there, he's most probably got about a 6 review a system that he has done in his HPI. You know, I'd have to sit there and pick and choose and find out where his location, quality, severity, which one would apply. So he most probably would have his 4 points, but he would have a week review a system. And you will find, I was going to have you do this when you went through the notes, but I could just pretty well tell you. And by here's his history of present illness. Okay. But when he gets down to his exam, he's so consistent, he does the same exam over and over and over again. He never changes his exam. So he's always at a level 5 exam. He's doing 10 exam. So I'm sitting there thinking, okay, where am I at in my decision making? So if I were to go look at my points, I know I got PET CT going on here, some radiology exams. So from Medicare's point, they would be giving him basically maybe 3 points. I would be giving him, because he has multiple radiology tests going on. They would be giving him 1 to 3 procedures, 1 point. I would be giving him 2 points. His lab, he's got some lab, got 1 point, 2 points. So I'm at 4 points, and they're at 2 points. So I got double the number of points on the testing. And he's talking about ordering a procedure, so he gets some more points there. So in effect, when you get down to that form, if you add up the points, the patient's really a high-risk patient, so I'm going to get the patient in the risk level as high complexity. But when I get to the points of the management option and data to be reviewed, I'm looking at most probably less than 3, so I'm going to end up most probably with a moderate complex 4 on their scale. But if I add my points up, I'm going to be at a 5 because I'm adding more points. See what I'm doing? So because of the way they got these point systems going down here, because your basic number of diagnosis and management option, they're at 3, I'm more than 4. Lab, they're at 3, I'm more than 4. So if you go down and look at the 3, if they got a high complexity, they agree with me, high complexity, but they're going to go over here and say, well, you got 3 points here for number of diagnosis and amount of complexity, and the risk in us is most probably moderate, but maybe high complex. They're going to drop him down to a level 4. And they're going to say, well, his history's a 4, his decision making is a 4, even though he's got a 5 exam. I would be giving him a 5 because he's got a level 5 exam. There's a lot going on with this patient. He's making a referral to an institution, a major institution. Now he might, this is so close, he may have enough points that would pull him up, because remember back in our management option, even though he didn't have any chemo going on, he is making a referral. But they only give him 1 point. They're only going to give him 1 point for that referral to that major institution. So they would be looking at this level visit here as a level 4. But from a complexity standpoint, and again, a lot of times if I'm not sure, I'll go to the doctor and say, can you tell me just how complex is this patient? Is this patient really a sick puppy? I mean, I kind of think she is because you're making a referral to a major institution. You got all these issues going on here. Some of them I don't understand because I'm not a doctor. But I know I got a patient with, I know enough about breast cancer that this patient's got troubles. So I'm trying to figure out how could they downcode this to a 4. Yes?
I think the point that you need to make also is that the examiners are not doctors either.
And I understand that.
And in spite of the fact that they're very resistant to your argument, and they can be, you still need a physician to argue with them, and you still need a physician to put as much meat as they can
That's exactly right.
in order to make it defensible.
See, he needs to put a little bit more in decision making here. I think that would have helped my case. I think that would have helped in that case. And his review system would have also helped too. But in this case here, what will happen with this, they would have set a 4, I would have set a 5, we would have appealed it, and most probably won it on appeal. My goal is to keep it from going to appeal. That's what I would rather do. See, I don't want it to go to appeal.
So what points are you saying are missing?
I'm sorry?
What points are missing in this medical decision?
I think in the medical decision making. He's saying one might want to biopsy a lesion at a distance from the primary tumor as metastatic, but he's not saying, I'm going to do that. he's making a recommendation to go to that other clinic, and I guarantee you he's talking to some referring doctors and telling them this is what he thinks should be done, right? So he should get points for going to the clinic, talking to other doctors. But he doesn't tell me what doctor, he just says clinic. It'd be nice if he would have said, this patient's going to have to see a medical oncologist, this doctor and this doctor when they go to that clinic. Then that would say, well, there's 3 involved. Or it'd be nice if he made a comment that he did talk to doctor, or he's going to talk to Dr. X at the clinic. That would have helped his case a little bit more. Because at the end, I can tell she's sick, but I'm not sure what he's going for. I assume he's going for trying to decide, is she really got really progressive disease going on here, and what treatment options should she get on a clinical trial, because there's most probably nothing available for her. See, I'm inferring that because I know he's making this referral.
The examiner is not going to go as far as you go.
It's exactly right. So when I go back and talk to him, that's why I will tell him. I will get in a discussion with him, say, just what were you planning to do here? What's going on here? You're not giving me enough information. And this is going to be should be a strong 5, but it's a weak 4, it's a borderline, and you and I are going to have to argue and debate this one. Do you really want to spend time arguing and debating this? No, Marty, I don't want to do that. Well, then do me a favor, give me a little bit more power in this here. Now, what I would love to do, again, the scribing process, basically, if you look at the assessment plan, that's everything the doctor should be doing. And the data, of course, the lab values are there. But if you go from the exam, if he's got a scribe in there, the exam can put that in to the system. And the scribe and somebody else can gather all the review of system and the HPI elements, right? So I can cut down on his time on transcribing, give him more time to give me more power in his note, which is what I'm looking for. I want to shift the paradigm to get staff to help him do other things, so he's got more time to do the more important things, to put something in that note that makes it really a powerful, great note that hands down, always be a 5. Always be a 5. Always be a 5. Any questions? And please, when you go home, share these with your doctors. Let them sit down and kind of go over these and maybe take the time to score them. And maybe what we need to do is come back after you kind of look at the scoring tool, and we may just have to have 2 or 3 hours. I'd like to be sitting at a table. What I really wanted to do is have half the table be the auditors and score it like Medicare, and have the other half score it with the specialty points and see what kind of level we came up with. But that would take 2 or 3 hours to do that. So think of this as an introduction. That's what it's about. And you have 10 notes. In some respects, that's true. I will tell you, yes, that is where I got my education. It is baptism by fire on my back. Okay? And you do have 10 notes in your packet that you can surely sit down with the docs, and I will tell you, don't tell your doctors, but every one of them are all level 5s. He billed every one of them as level 5s. Those are all level 5 type notes. Okay? But I could tell you now, and 5 years ago, I would have had no problem. These would have been easy level 5s. Today, based on these new forms I'm seeing out there and what's going on, I'm just a little bit more cautious now. And that's the message I want to take home today. What I saw 5 years ago, what I'm seeing today is more complex, but I'm smart enough to know I want to stay 2 steps ahead of them. I want to stay 2 steps ahead. I want to complain about the audit forms. I want to create my own audit form with my own points. And then I want to improve my note so it's more meaningful, so when somebody reads it, it has more oomph to it. The doctors now have more money in their back pocket because they're coding right, and I can get them more help because I'm telling you what's going to happen here in the next year or 2. The population's aging. I'm going to have more Medicare patients dumping in the system. Whatever is today, in the next 2 years, it's going to double. So whatever patients you're seeing today, your volume's going to be 25% more in 2 years. And I'm not kidding. 25% more. Unless somebody comes up with a cure for cancer. And there's no doctors out there. I need more nurses that can do this review of system and scribing, and I need more extenders to help the doctors. And I got to get them trained, and I got to do it fast. Because I know the demand's coming. And that's why I've got to change the wheel. And I got to start working on this. Okay, let's go to patient 2. This was a diagnosis breast carcinoma stage 1. Status post bilateral lung transplantation. Listen to that one. bilateral lung transplant. Chronic hypersensitivity. What is that word, doctor? What does that mean? Huh? The last thing here, this here. That's a third problem, right? Something in the lungs, something going on with the lungs. So good news here, I think I got 3 problems. So I can count 3 points on diagnosis, but it should be about 10 what this lady's got. So again, you can see he goes down, appetite's fairly good, stable, denies chest pain, continues to have intermittent, non-productive cough. So I'm getting some good feedback here for his HPI. Okay. Patient does have, so she's got some lung problems going on with her edema. Bruising, bleeding, denying symptoms, bruising, bleeding. So when I sit down here, I count up, he had about 6 or 7 reviews of system. Okay. And her visual acuity's decreased. Okay. Oh, we're going down the wrong way. Whoa. Don't be doing that to me now. We're doing really good here. We've had no blow-ups. Okay, so the patient's on some calcium vitamin D twice daily. So he's got some digital screening. Mammography was performed, but that was back in 2010. Now, this is an interesting question. Does he get credit for something that happened back in 2010 that's mentioned in the note? Or are they going to say, well, that really don't get any credit because that was something that happened in the past? But in reality, if he's got a note, he's saying, I relied on that to help me to make my decisions because I have to see what happened in the past. Even though that part of the note may pop up every time, right? Because that's your cut and paste note, because that's your past history. Because I would argue if it doesn't need to be there, then it shouldn't be there. But if it's there, he should be able to get credit for it. But some auditors don't believe that. Because they say, well, that's really not affecting what he's going on today. Well, I don't know. I'm not the doctor. I'd have to ask him. Did he rely on that information to help him to make his diagnosis going forward? Allergies, got medications, history of present illness, screening mammography was performed back in 2002. Left breast. This is more history here. Biopsy was performed, so he's talking, he's giving you some history of what's going on with this patient and the disease process. This breast was reviewed by Mayo. So he's given our grading. So then he goes down, he does his exam. Look at that, he's very consistent. In his assessment, so again, so the patient had surgery. Tumor was grade 2-3 lobal. Patient completed 4 cycles of adricytoxin. So he's given us more information. Patient's under care of a family doctor. She had some things done in Colorado. That's where I think she had her lung transplantation done. Now we're really getting down to what she's here for. Continues to have nausea and feels sick to her stomach. Symptoms have decreased lately. The patient denies vomiting, however, states her vision remains poor. And he wants her to continue taking this oral medication. See, so here he built a level 5, but he's got it in the exam. I'm not sure he's gotten a review, and I think at the end of the day here, he's gonna fall weak on his decision making because basically all he's doing is prescription drug management for this patient. But he does have lab here. He's ordered CBC, CMP, HDL, CA 15-3. So that's 1, 2, 3, 4. So he's going to get count for ordering 4 lab tests. Okay. On his ordering diagnostic testing. Where I would most probably give him 6 points because that CA 15-3 is a little bit more complex in my mind. But see, again, I have to go back to the doctor and say, is that more complex? Or is that just as comparable to a CBC or CMP? He's got to tell me that. But they would say that's worth 4 points. I would say because it's a cancer patient, that should be worth 6 points. Okay? And of course, since she's on prescription, I know right away I'm looking at a level 4 decision. Okay? So in this case here, I would most probably go back to him and say, I don't think you're going to get any cigar for this one. I think he would have trouble. If he did a little bit, I mean, the patient's got the diagnosis there. The diagnosis is there. I just don't think he's given me enough information. The exam's there. right? I got in the exam, but I'm losing points between decision making and review a system that's going to pull me back a little bit, that's going to make this a questionable note. And I don't like questionable notes. I like slam dunks. I don't like to have to argue these hard things like this. Okay? But I can guarantee he built a level 5 because I know him. And he would argue a level 5 on this and he would win. He knows how to do it. He's good. He's good. But he's got to improve. All right. Third note. I love these type. So we got the same subjective. So if you go down, you can almost see my review system every time is about the same, right? You know, denies chest pain, difficult cough, fever, infection, night sweats, skeletal pain, fatigue, weakness. See, so I got to go back and say, you got to put a couple more things in there. You're missing some. Past family social, we did there. He's still doing good there. He throws in his history of present illness. She's a 72-year-old female, hematology consult. Now, this is one I got to get 3 out of 3. Okay? In other words, follow-up visits, I get the highest points 2 out of 3. When you get to the consult, new patient visits, you got to get highest points 3 out of 3. And subjective, objective, and decision making. And that makes it even more challenging. Because I would be back talking to him and saying, you got to tell me how complex this case is, because you're hitting it in the exam. He's talking about these gene mutations were positive. He's going down here at the present time the patient has significant constitutional symptoms, and thus will continue. So she's kind of stable. So I'm looking here kind of at a level 3 decision. He's got CBC, I don't know what this JAK2 gene mutation. I had to go do some research and find out what that is. And he wants the patient returned in 3 months, at which the CBC and ChemPan HEL will report it. So he's going to get 3 points for the lab, and that's it. Yeah.
Discrepancy in the note, because up in the first part of the note it says Jack mutation was positive, and then on his plan he stated that he will awaits the results of the Jack mutation.
Let me take that off there, because he can't see. Up here, you mean where it's pending? Where was that under review?
Yeah, he says right before O.
Oh, right here? Yeah. Oh, interesting. Now, is it possible that he could, this is the second one he's ordering, or is it the second one?
Does it say that he reordered?
Well, I don't know. You're right. See, he's leaving some holes here. Good. Thank you for that. I'll make sure I point that one out to him when I see him. But most probably the best he could get out of this might be a level 3. Pardon? Will be repeated. Did you see that? Oh, here it is. Yeah, this will be repeated. See, so the question is that lab study that he relied on back whence that he's looked at, now he's one that repeated, how much complexity does that add to the note? And how many points should I give him for that? And would that be enough to drive me up a notch? But under their scenario, it wouldn't. This would most probably be a level 3 because they say he doesn't have enough in his decision-making and in his history to drive this up to, say, a 4 or a 5. They wouldn't give him enough credit there because they wouldn't give that much credit to that lab, although the lab is most probably a pretty complex lab. Because, again, this is being done someplace else. He's sending that out. And the patient's pretty stable, so that's what they would look at. They say, well, this is a stable patient. That's level 3 decision-making. Got some lab going on. Hey, there's not much going on with this patient. So that's how they would come up with a level 3. I know this is new, a lot of you billing kind of guys. I hope we're not overwhelming you, because I get overwhelmed with this. But you see where I'm going with this? You understand how the flow and how you have to look at all these points. You have to look at all these different things that you got to, and you got to sometimes go back and read the note 2 or 3 times. Typically, auditing a note, on average, takes 15 minutes. By the time you start, go down, look at everything, think about it, document it, count the points, go back and look at it again to make sure you didn't miss nothing, because you're looking at no less than 60 to 70 line items here to try to figure out if you got everything. And maybe then consider you have to go talk to the doctor about things that you don't understand. Or you get on the website and you got to look things up and try to figure out what it is. If you're trying to understand what the doctor's doing, so you don't have to bother them because you're trying to learn yourself. So it takes time. It does take time. So the more we can get them to put in the note in a meaningful way, from a narrative way, that saves me time because I can understand it down at my level. And by the way, I'm not a nurse. I'm not a doctor. I'm an accountant. So I know how to count 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. When I get into complexity, I start thinking, well, how complex is this relative to something else? That's my accounting training because I'm trying to look at this is something simple, this is something intermediate, this is something up the ladder. But I don't know because I don't know enough about medicine and how to take it across to a comparability. I always go, my benchmark's always a patient with a sore throat. I always say, if the patient's a sore throat with a level 3, what am I doing over here? What am I doing over here? And that's how I get from there to here. Okay? Got one more, and I'll let you go. Or we'll ask some questions maybe, and then I'll hang around here if you guys got more things you want to talk about. So here's a patient here coming in with small cell lung cancer, limited disease, ovarian cancer. So she's got 2 major disease issues going on. So right away, I'm thinking well, that's got to be, I should be looking at a level 5 here unless this patient's cured and nothing's going on. So what I will do is I'll run all the way down to the back end because I already know his exam's going to be, I don't even have to count that. So I'm going to sit here and spend my time here. And see, here we go. And he's talking about, the patient had a CT-guided biopsy performed in 2010, CT scanning of the chest, abdomen, pelvis, 2010, right lower lesion measuring. So he's putting measurements in there. So you can tell he's doing a lot of review here. So he's looked at a lot of information. Patient was evaluated at the Mayo Clinic, and since then, no evidence of disease outside the primary tumor. Recommendation of the chemoradiation. Patient was started on carbovecibit at Mayo, felt that the cisplatin might cause renal dysfunction. Carbo was combined with standard vecibit. Patient continued the first cycle of chemo. Patient states that she began irradiation on January. So the patient's getting chemo and radiation. She's going to come in here and begin her 3rd cycle of her chemo. Cycle 3, day 1 of her chemo. Patient will receive saline hydration, aloxidecadron, carbo. He's hitting a home run with me now. Because I'm going to count my drugs, right? 1, 2, 3, 4. But I don't have to count the drugs. They're the ones counting the drugs. So I'm looking at this as an easy level 5. Because I got a decision because the patient's getting these complex chemotherapy drugs. I go up and look at my exam. I know I'm not hitting a review on the history, but I got a slam dunk on my exam and the chemo. But I can guarantee you they would try to downcode this to a 4. Because they would say, patient's coming in 3rd cycle, nothing's going on. Patient doesn't have any new complaints, no new problems, and so therefore, that's how they would get to a 4. If you count the points up, you'll see it'll drop in. You count my points up, you'll come up with a 5. Interesting, huh? 2 different opinions, 2 different thought processes. And remember, their audit form is using a primary care point system. Mine is a specialty point system. But I need to get buy-in from the doctors out here and other doctors that makes sense. Then we've got something to fight for. And that's how we stay in private practice, ladies and gentlemen. It's not going to be easy.